Okay, welcome everyone. It is a little bit after 12, so we're going to go ahead and get started. We have a full and accomplished slate of speakers today that we're eager to get to. Welcome. I'm Katie Crashall. I'm the Executive Director of the Solomon Center for Health Law and Policy at Yale Law School. On behalf of our partner in this series, the Petrie-Flom Center for Health Law, Biotechnology, Health Law Policy, Biotechnology, and Bioethics at Harvard Law School, I'd like to welcome everyone to the second in our series of our COVID and the Law Forum. Today, the topic that we will cover is what COVID-19 teaches us about health justice and the path forward. A couple of quick housekeeping things before we get started today. Feel free to submit questions throughout our presentations today. You can submit them anytime using the Q&A feature found in the meeting controls at the bottom of your screen. You can also submit questions by tweeting and using the hashtag COVIDLawPolicy. In addition, if you have any technical issues in interacting with us virtually today, you can email petrie-flom@law.harvard.edu. And I would also just encourage you to check out the presentation. We will be posting it with captions in a couple of weeks after we have the time to get the program captioned and posted to our respective websites. And as you can see on the slide that we have up, that's how you can get in touch with us. I think that's it. Our next panel, if you're interested after today's will be so wonderful and you want more, we'll focus on the use of biotech in the COVID-19 pandemic, and that will be a week from today at the same time slot on February 23rd from noon to 1:15. So with that, it is my absolute pleasure to go ahead and introduce today's speakers. I'm gonna just do a very brief introduction for all of our speakers in the order in which they'll give their talks today, and then we'll have time for Q&A for all of our speakers at the conclusion of our last talks. So our first speaker today is Seema Mohapatra, who is Associate Professor of Law and Dean's Fellow at the Indiana University Robert H. McKinney School of Law. Her talk today will be COVID's Children, the Need for Health Justice. Then we'll have Zoe Adams, who is a MA candidate in History of Science and Medicine at Yale University, as well as an MD candidate at the Yale School of Medicine. Her talk will focus on the changes in the provision of methadone for people with opioid use disorder during the COVID-19 pandemic and its implications for future policymaking. Next, we'll have Elizabeth Dietz, a PhD student in biology and society at Arizona State University, presenting reproductive justice after the pandemic and how personal responsibility entrenches disparity and limits autonomy. Then we'll have Joanna Erdman, McBain Chair in Health Law and Policy and Associate Professor of Law at Dalhousie University. She'll be presenting a piece, Abortion at Home, COVID-19 as the home as a regulatory space of abortion care. And then we'll have Ariel Giraud-Kleiman, Associate Professor of Law at the University of San Diego School of Law, presenting her work on post-pandemic poverty law towards a more responsive safety net. So we have a full slate. I'm looking forward to it. And with that, I will hand it over to Seema to start us off.
Great. Thank you so much for having me here today. And before Laura kind of gets the PowerPoint up, I just want to thank both the Petrie-Flom Center and the Solomon Center for having me, and I'm really happy to be on this panel. I'm just waiting a little bit. I don't know if they're going to share. I don't need the slides, so I can. Okay, never mind. Perfect. So I am going to be talking about my chapter for this, the book that is going to come out of the series of talks, which is called COVID's Children, Health Justice for Children During and After the Pandemic. And I'm really excited to be able to share this work with you today, and especially because the whole panel is focused on health justice. And unfortunately, what we've seen during this pandemic is that this vulnerable population of children has really been ignored. And so could I get the next slide, please? So the way that the series, the seminar series has been structured as disruption, impact, and legacy. And that's how I'm going to structure my talk, and that's how my chapter is structured. And so what I want to talk about today is how children's lives have been disrupted during the pandemic, and also kind of focus on the population of children that has been the most impacted during this pandemic, and which is children of color, particularly African-American children, Latino children, and Indigenous children. And this often gets kind of mixed up in all the conversations about COVID law and policy. Is who is the most impacted are children, and they're the ones with the least voice. And so I'm going to give you some examples of how their lives have been disrupted during this pandemic. And then I'm going to talk about the impact that these disruptions are having and will likely have in the future. And then I want to talk about the legacy that we can choose, that we can decide to have, right? And so we can continue the way that we have been, where children are an afterthought, and we, later on will document the horrors of what happened during the pandemic without making any kind of structural change. Or what I suggest here is how we can use a health justice frame in order to center children's experiences during this pandemic and after, in order to help make sure that the harms that they have suffered are lessened, and that there are structural changes so that we don't repeat this again. And so if I could get the next slide, please. So these are just a few headlines in terms of some of the things that have occurred in terms of disruptions in children's lives. And I'm going to talk about a lot of them, and this is not a comprehensive list. But one thing I want to note is that first is thinking about children as patients. And so although COVID-19 doesn't have the same kind of serious impacts in general on children as it does for older adults, what we've seen is that the children that are affected, the ones that have serious consequences from COVID-19, are disproportionately African-American and Latino. And so we've seen 75% of the deaths of children in COVID-19 are in these populations. So very, even though we can say that this is, generally safe for children, if it is your child that is impacted, and it's more likely that a child of color is going to have serious consequences than white children. If we could go to the next slide. So I want to kind of break down some of the things that are some of the disruptions that have occurred, and give you some statistics as well. And I want to give you statistics kind of nationally, but then also I'm going to focus on New York State for a few reasons. New York State has actually, there's a couple comprehensive studies of children in New York State to kind of give you some data about how children have been impacted. This was the first epicenter in the US of the COVID-19 infection. And then it's a little bit when we think about all 50 states and we think about these larger numbers, sometimes some of the details get obscured. So I wanted to use one, New York State as a case study. And I want to, talk about the different ways that this pandemic is impacting children. Some that you've probably thought about, or that you might have been experiencing yourself if you're homeschooling your kids, if different, if you have children, but also things that you might not have thought about. And so, in terms of, we already know that there's stark data in terms of how COVID-19 is impacting the population. We know that if you are Black, Latino, or Indigenous, you are more likely to have been infected, more likely to have been hospitalized, and more likely to die than than people that are white. What does that mean for children? Well, those disparities, they follow through with children. And so you are more likely as a child to have a parent that has been infected by COVID-19 if you are either African American, Latino, because also we know that most essential workers in this country that have been deemed essential and are going to work in person are people of color. And so their children, if they are more exposed, they are more likely to have a parent that is exposed to COVID-19. And what we're seeing in some of this data is that we're seeing that you're in New York State, for example, 1 in 600 children lost a parent already to COVID-19 in New York State. 1 in 600 if you're African American, it's 1 in 1,500 if you're white American. And so you can see that those disparities are pretty stark. And we know that, you know, when we look at these populations, there's underlying disparities that minority children are more likely to experience than their white peers. So crowded living conditions, food and housing insecurity. So when schools are shut down, one of the things that we're seeing is schools as a safe haven, when they're a way that many children that don't have homes get their food, get shelter, get safety. You know, if you have a parent that is an essential worker, you can't work from home, that is where you have someone taking care of you. School is also a place where people actually get healthcare services in many schools. And so when we're thinking about school, it is not just the education gap that people are feeling from the fact that school has been shut down in many places in the country since March. And if you are, you know, having to have your child go to online school, if you are working yourself outside the home, especially for young children, there is a gap. And what we're seeing is there's already reports, and I'm going to use New York as an example, there's already reports of schools targeting certain parents for not having their child logged in for online school. The anecdotes that we're getting are all of these anecdotes are with Black and Latino children. And even though statistics show that we're not having the same kind of truancy reports as we did before it was online school, just the threat of having child and family services involved is particularly worrisome for poor parents of color, because we know that poverty is a comorbidity with having your child taken away, and we see that this is occurring already. And so things that we might not, you know, when we're thinking about schooling, we might not think about the fact that the lack of in-person schooling or support for online schooling impacts certain children differently than others, right? And so, you know, other things that I have on this slide, a lot of times school is where children get their services if they have if they're special needs or have special services. There have been attempts to have this remotely, but a lot of times there's a gap here. And so people with special needs already, children with special needs are falling behind here. We have seen the increase of children that are living in poverty. And so children that were already living in poverty, children that were undocumented or had parents that were undocumented, were already a vulnerable population. But what we see is that we have new people that are in that category that are now newly impoverished, and they do not usually access the same kinds of services that are available to them at the same rates as people that have already been in poverty. And so this is another group that is kind of falling, to focus on here. Obviously, there is mental health effects of not, isolation, people that are dealing with the stress of the pandemic, and then a lot of childcare opportunities are closed down because of the pandemic. And this also affects disproportionately people who cannot work from home and who are having to be outside the home. And so all of these things, and again, I said this is not a comprehensive list, but I just wanted to kind of, have you think about some of the disruptions that are occurring. If we get to the next slide, please. Okay, and so there are many impacts of these disruptions that we know is already occurring, that we can already predict is happening from social science data, right? And so we have poorer health and developmental outcomes that are associated with poverty, that are associated with disadvantage. We already know that the first few years of life are vitally important in terms of schooling, in terms of nutrition. And when we have these kinds of disruptions that COVID-19 is giving us, we can expect the vulnerable populations, especially people that were poor, people of color that were already disadvantaged, to be further disadvantaged by this pandemic. I already mentioned this kind of specter of foster care, but this is a real issue and a real concern as more people are falling into poverty. There is an eviction moratorium now. However, the risk and the kind of threat of evictions is looming over families, and this also impacts the security that their children feel. And in terms of the home life disruption, this is not only if you've lost a parent to COVID-19, right? We already have certain families that were already more at risk. I know we have a panel that is, going to be talking about people with opioid use disorder, but we have data where kids that were already living with kinfolk because of opioid use disorder are being further disadvantaged during this pandemic. If we go to the next slide. So I want to make sure that we focus on what can be done, right? We know what the problems are, what can be done, how can we change the way that we are reacting to this to be more proactive about this. And we know that children have been an afterthought during this pandemic. And so what I have been working on for the last few months with some coworkers, colleagues, and I'm going to be using some of the frameworks that we have developed in prior work. Professor Emily Benfer, Professor Lindsay Wiley, and Professor Rakaya Yerby and I published a piece about health justice strategies for the pandemic. And if we get the next slide. So these are a couple of models that we created in that article that I want to show how can be used to focus on children. And so if you look here, we have the structural determinants of health and the intermediary determinants of health. And I'm not sure if you can see this clearly, but what we're focusing on is how subordination itself, discrimination, poverty, how they relate to these political and legal determinants of health, and how that impacts material and environmental circumstances like housing, like healthcare, like employment, and cause these disparities in health outcomes. Now, if we go to the next slide. So the health justice framework, which really was developed, it's been used in many ways, but in health law particularly, Professor Lindsay Wiley and Professor Emily Benfer have published about social justice in healthcare and a health justice framework. And so in this model, we show how we can have, structural remediation. That's one of the tenets of health justice as we frame it. How we can engage and empower the communities impacted to provide legal protection, financial supports, and accommodations. If we go to the next slide. And so this is another model that Professor Yerby and I came up with for a forthcoming Emory Law Journal article. And again, this is talking about how we can look at, through a health justice frame, but I have here highlighted the resources, because that is the main thing that we need to make sure we focus on. And so you can see that the resources that I've highlighted, a lot impact children, childcare, education, employment, housing. Teen employment is also a big, especially for children living in poverty, teen employment is a big part of the financial well-being of the family, as well as the employment of their parents. The next slide, please. So I only have a couple of minutes left, but I want to make sure that we think about how legal and policy responses can address these social determinants of health and structural determinants of health. Next slide. And so when we are thinking about the framework and how it can help children, you know, I want to think about the fact that we need to think about how the burdens of any kind of public health interventions, whether it's shutting schools down, whether it's determining who's an essential worker, how they can be mitigated and minimized for marginalized communities, and then also making sure that we involve the people that are impacted so that children are not just an afterthought. Next slide. And so two things that I focus on in the chapter are education and decisions about reopening and closing businesses, and thinking about children and particularly children of color, how they're impacted by these policy decisions. Next slide. And also making sure that we center the experiences of children. Next slide, please. And then making sure that we have representation of the communities that are impacted. And so that even, people that represent the interests of children in those communities and older kids themselves must be engaged as leaders so that they are, the problems that are impacting them, they can tell policymakers and there can be resources placed to the areas so that it is not a top-down approach. Next slide. So I kind of rushed through the end of that, but this is my contact information and I'm happy to talk about this more in question and answer. Thank you.
Okay, I'm just going to share my screen. Okay, thank you so much, Professor Kraschel, for the introduction, and to the Petrie-Flom Center and Solomon Center for the opportunity to present today. I'm really excited to discuss take-home methadone for people with the diagnosis of opioid use disorder, or OUD, during COVID-19, and the implications for policy. And I just want to give a huge thank you to Dr. Ayana Jordan, one of my mentors and the principal investigator of the project, who will be joining us during the Q&A. So this is just a brief roadmap of my presentation today. I first want to make sure we're all on the same page in terms of understanding what methadone is. Next, we'll go into its current regulatory scheme, focusing on restrictions on take-home methadone, meaning the amount of methadone doses patients are allowed to bring home with them. And then I'll go into a brief history of methadone. And then I'll go into how COVID-19 prompted changes in methadone regulations and our project, which focuses on patient experiences with increased take-home methadone. And then I'll close with some policy recommendations we've drawn from the broader literature and our work, as well as future directions. So here I really just want to show what happens when a patient starts using opioids for the first time. So initially they jump back and forth quite dramatically between feeling normal and euphoric. And then over time, patients develop tolerance and physical dependence and begin to use just to prevent withdrawals. And what's nice about methadone is that it's a full opioid agonist with a longer half-life, and it evens out the ups of euphoria and the downs of withdrawal, which in turn stabilizes people with OUD. So as you can see on this slide, methadone has many benefits and a strong evidence base. So it's been shown to decrease mortality, the risk of fatal and non-fatal overdoses, the risk of infection due to IV substance use, and it also increases treatment retention, employment, family stability, and pregnancy outcomes. And methadone is the oldest medication we have for the treatment of OUD, and it's more effective at preventing overdoses when compared to other treatment modalities like abstinence-only or detox approaches, outpatient behavioral therapy programs, etc. So methadone must be provided within a federally regulated opioid treatment program, or OTP for short. And these are spaces with very stringent rules surrounding how the medication will be administered. So these are not normal doctor's offices or clinics. And patients must report to clinic at very early hours, almost daily, to receive their medication. And they must wait in stigmatizing lines, walk up to a counter, and receive their dose under directly observed therapy, or DOT, which mimics behaviors in carceral systems because patients have to be watched as they take the medication and lift up their tongue after they've swallowed it. And patients must take time away from childcare, school, and work to access methadone, all activities that promote adherence to treatment. So despite the extensive body of evidence supporting its effectiveness, methadone is subject to 3 layers of federal regulation, making it the most regulated pharmaceutical medication in the United States. So the first layer is the FDA. They monitor the safety and efficacy of methadone, and they've approved methadone for specific medical uses. One use is for the treatment of chronic pain, and the other is for OUD. However, methadone can be prescribed within doctor's offices for the treatment of chronic pain, versus for the treatment of OUD, patients have to go through that OTP model. Although there's far less evidence for methadone's efficacy for the treatment of chronic pain. So this speaks to how stigmatized methadone is for the treatment of OUD. It's the same exact med, but it's being prescribed for chronic pain with far less regulation. And the second is the DEA. It's regulated by the DEA because it's considered a controlled substance with potential for misuse. And then the third most unique layer is the Substance Abuse and Mental Health Services Agency, or SAMHSA, and they set the accreditation standards for OTPs and promulgate guidelines that govern the frequency, dosage, and dispensing of methadone by OTPs. So now I'd like to focus on SAMHSA's restrictions on take-home methadone. So you'll be hearing me refer to take-homes or take-home dose, or THD, throughout. And these were the regulations that dictated how patients became eligible to receive take-home doses prior to COVID-19. So it took 90 days for a patient to become eligible to receive 1 take-home dose per week. And then after 1 year, that patient could be eligible for a 14-day supply, and after 2 years, a 28-day supply. And under the SAMHSA guidelines, OTP leadership can evaluate a patient's eligibility for take-home dose privileges based on the regularity of clinic attendance, absence of recent substance use and criminal activity, and the stability of a patient's home environment. And such subjective determinations invite bias, particularly against Black, Indigenous people of color, or people living in rural or economically disadvantaged communities. And I just want to stress that take-home dose privileges can be life-changing for patients. Not having to come into clinic daily can positively impact quality of life, employment, patient sense of control, and agency over their treatment plan. And these federal regulations have changed little since they were first established in 1972, and fears of diversion, meaning the illegal street sale of methadone, and safety concerns are still used as justification for the fact that the regulations continue to be the way they are. So why can't methadone be a medication you easily take home with you, like insulin? We have to look to some of the socio-political history to answer some of those questions. So, if we're going to talk about the history of methadone, we have to think about President Richard Nixon, who is most famously known for starting the war on drugs in the late 60s and early 70s. However, this must be contextualized in a long-standing history, beginning in the 1920s, of the US government's responses to opioid use among different racial groups, where opioid use was criminalized among Black and Chinese populations versus viewed as a medical condition when white Southern women used opioids. So we don't have time to get into all of that earlier history, but all of this is to say that vilifying minoritized communities for substance use is not anything new. And Nixon established punitive drug laws in the 1970s, but at the same time, he championed methadone as a key element in his offensive approach to drug abuse. And so why did Nixon get behind methadone? So in the mid to late 1960s, physician researchers framed methadone as a way to control Black substance use and drive down crime, and they published these findings in major peer-reviewed journals. And because of this framing, methadone actually facilitated Nixon's tough on crime agenda. So what happened when OTPs opened on city streets? So as a result of the Nixon administration's acceptance of methadone, there was a lot of backlash from many different constituents when methadone clinics opened in urban spaces. So from white gentrifiers to small business owners, to the Black Panthers, even hospital employees, that led to the relocation of methadone clinics to locations unfit for the treatment of patients, like a retired Staten Island ferry boat, a school basement, among other areas. And this occurred from the early to late 1970s. And this history has been extensively studied by physician anthropologist Dr. Helena Hansen and historian Samuel Roberts. And city officials, police, community residents, and journalists also grew anxious about the illegal sale of take-home methadone in the early 70s. So this is a headline, a front page headline from the Boston Globe. And these diversion concerns were greatly exaggerated and fueled by the fact that patients on methadone were considered to be criminals. And this led to further restrictions of the regulations surrounding take-home methadone in particular. So it's important now to highlight some of the differences between methadone and buprenorphine or Suboxone, which is another medication used for the treatment of OUD, which is slightly different pharmacologically. It's a partial opioid agonist, and it's far less regulated compared to methadone. And there's a significant racial disparity in terms of who is more likely to receive methadone versus buprenorphine. So white people are more likely to access buprenorphine compared to Black and Latinx communities where there's a higher density of methadone clinics per capita. So what might explain this racial disparity? Again, we can look to history for some answers. And unlike methadone, which was framed as a way to drive down crime in Black communities in the 70s, in the 1990s, Reckitt-Benckiser Pharmaceuticals, which was the pharma company that manufactured buprenorphine, used their lobbying power to found a nonprofit organization and launch ad campaigns that framed buprenorphine as a solution to opioid addiction experienced by white suburban communities. So this video series, Mike's Story, highlights the typical white opioid sympathetic narrative, which was different than methadone, which was framed as a way to, again, like we've talked about, drive down crime in Black and Latinx communities. And this racialized framing convinced members of Congress to allow physicians to prescribe buprenorphine without the stringent regulations that govern methadone. So it could be prescribed by primary care providers in office-based settings. And unlike buprenorphine, methadone did not have the backing of pharmaceutical lobbyists. And so this continues to be how things stand today. So methadone is dispensed in OTPs, it's heavily regulated. Buprenorphine is primarily used by white people and it's less regulated. And it's been this way for decades, despite these racial disparities and the criminalization of people with OUD. So when COVID hit in March 2020, SAMHSA changed the way methadone was dispensed, not out of concern for what would be best for people with OUD, but because of social distancing protocols. So it took a pandemic to change the climate and minimize the regulations on methadone, which people have been advocating for years. And these relaxations allowed clinically stable patients enrolled in OTPs to immediately receive either 14 or 28 days of take-home doses, regardless of how long they had been enrolled in treatment. And this was a historic and impactful shift, and it received a good amount of national coverage. And COVID-19 created an opportunity for us and many other research groups across the country to study how this increase in take-home doses would impact treatment outcomes and patient preferences, with the overall goal of improving access to life-saving medications for people who use opioids. So our study has multiple sites from across the country and is ongoing, but today I'm going to present some data from a subset of patients who received increases in take-home doses from one of our sites, which was an OTP in Nashville, Tennessee. And out of the 22 participants who we surveyed, we were able to get 15 of the 22 participants' demographic information. 47% identified as women, 53% as men, the majority identified as Caucasian, and 1 identified as Indigenous. So as shown in this graph, all patients received increases in take-home methadone doses as a result of SAMHSA's exemptions. But it's important to note that even after the exemption, no one from this sample or this OTP received 14 or 28-day take-home. So in other sites across the country, this wasn't necessarily the case, but it highlights how not all OTPs incorporated SAMHSA's guidelines uniformly. So here in this table, we're looking at safety measures related to take-home doses from all the 22 participants. We looked at how patients store them, if they were able to keep them locked, if they missed doses, took more than prescribed, whether there were any overdoses, and whether patients shared, gave away, or sold their take-home doses. So in terms of storage location, patients reported many different modes of storage, but the majority, 86%, kept their doses in a lockbox. And regardless of how patients stored their medication, all of them were able to keep it locked. And only 2 out of the 22 people missed take-home doses and cited transportation difficulties as a reason. And only 2 of the 22 took more than prescribed, and this was for the purpose of treating withdrawal symptoms. And none reported overdoses since the increase in take-homes, and none reported diversion. So the next large theme is patient preferences. So 21 out of the 22, or 95% of patients, stated they preferred taking the medications with them. I've got a 2-year-old who is immunocompromised and an 88-year-old father who's at risk. I live at least an hour and a half away. I used to worry about whether I would make it on time. And then 21 out of the 22, or 95%, stated that the increase in take-home doses had a positive impact on their quality of life. So it feels like you've accomplished a lot more, not having to go as often. I've been able to hold down a job. Lots of participants stated improved mood and sleep quality. And just to summarize, most participants were not taking take-home doses before COVID. And after SAMHSA's exemption, most patients received a 4 take-home dose increase, so not the 14 or 28 days as SAMHSA recommended. And few adverse events or practices were reported, and patients overwhelmingly preferred take-home doses compared to coming in daily, and stated that take-homes improved their quality of life. So it's really this preliminary data, along with the work of so many others who have published in this space, that leads us to call for methadone regulations to change. So our recommendations fall into 4 basic categories: methadone federal regulations, social and reparative justice, financial restructuring, and harm reduction. So in terms of federal regulations, we have to increase take-home doses. Scholarship coming out within the last couple of months has found little evidence of diversion of take-home doses and no overdoses as a result of take-home since the increase. There's also no reason to limit methadone to OTPs. It's already prescribed in outpatient settings for the treatment of chronic pain, and it should be available in more settings like primary care offices and pharmacy dispensing, as is done in the UK, Australia, and Canada. In terms of social justice, our research doesn't so much focus explicitly on these principles, but there's a large body of research focusing on this. Policies going forward must be patient-centered, and what I mean by that is what is easiest for people to maintain recovery. We have to de-emphasize policies surrounding drug use that mimic carceral systems. And then in responding to people with OUD who have co-occurring mental health diagnoses, we have to remove police from these encounters in order to minimize violence and even death for Black individuals in particular. In terms of financial restructuring, not all but some OTPs are disincentivized to give take-homes because they receive more money if patients come in physically. And this was the case in our data at a for-profit OTP where no one got 14 or 28 days because the OTP received less money for this. And then simple harm reduction principles, so access to sterile syringes and the establishment of medically supervised safe consumption sites, which have been shown to decrease overdose rates in places like Canada, where they're more widespread. So I know I'm out of time, but just to sum up, limitations, the data I presented today is from one cohort. It's a small sample size in a mostly white population. Going forward, we're actively collecting data on patients' experiences all across the country from different types of OTPs. We're going to focus on things like geographic differences, racial and ethnic diversity, financial incentives, and then of course publications and continued scholarship. And these are my references. And huge thank you to our team of partners and researchers and students working with us, and to our funder FOR. And any questions will be addressed in the Q&A. Thank you.
Hi. Thank you so much for taking the time to listen today. I'm Liz Dietz, and I'm a PhD student in the School of Life Sciences at Arizona State University. Thanks to the organizers of this seminar series and my excellent co-panelists for the opportunity to talk about the work that Rachel Zacharias, Kim Mutcherson, Josie Johnson, and I have been doing. Today, I'm here to talk about the arc of personal responsibility in US policy and how, by examining responsibility during COVID-19, we can see even more clearly how reproductive justice offers a way forward. COVID-19 laid bare the responsibilities that American laws, policies, and society have long placed on individuals to ensure their own health and well-being. An ethic of personal responsibility guides the pandemic response. It's a rhetorical move, it's a term of art. It shifts responsibility from governments to individuals, and it enforces prescriptive norms, particularly about reproduction. Personal responsibility restricts and opposes reproductive justice, which women of color feminists have defined as the right to have children, to not have children, and for families to flourish in supportive environments. So reproductive justice goes beyond reproductive rights. It's an analytic, it's a movement tool. It describes how people are inseparable from the systems that they're in and how those systems make their choices possible or not. The US response to the pandemic has been structured by making recourse to the ideology of personal responsibility. For example, mask wearing treats pandemic spread as a matter of people exercising their own rights, obviating the interconnected health effects of what is not, in practice, a merely individual decision. Essential workers are required to work, but are also left to their own devices for their health and economic well-being. In each of these cases, it is characterized by shifting responsibility from the government to individuals, counting on them alone to make the right choices under conditions where right is not clear, supported, or a matter of mere individuals. Our work takes seriously the harms in these invocations of personal responsibility. But in seeking to understand the role of responsibility in US policy, we have also found its expression in a number of other ways relating to reproduction during the pandemic. In these, responsibility is not characterized by this unsupported shift from governments to individuals, but rather is a recognition of an individual autonomy that ought to have already been supported. So in this talk, I'm going to articulate a few key moments in US history that show how the ideology of personal responsibility has been integral to US policy. It's a racialized notion. It makes demands of Black and Brown Americans far more punitively than it does of white Americans. It has been made integral to reproductive policies, shifting burdens from governments to individuals, but not attending them with the material conditions that would make them realizable. Then I'll offer an account of how a kind of personal responsibility has been promoted and required in the pandemic. In contrast to the extractive legacy of personal responsibility in reproductive policies, these examples will illustrate where hurdles have been removed in line with longstanding calls from reproductive justice advocates. In them, responsibility has been relocated to individuals. But through the removal of barriers to its effectuation, these individuals are afforded the material conditions for more meaningful choice and not less. These policies allow responsibility without punishing failure, but they also tell us something meaningful about the concept of responsibility itself. Finally, I'll affirm the value of reproductive justice as a framework and a goal for building personal power while taking interdependence seriously. We're not arguing as apologists for the concept of personal responsibility. This is not a personal responsibility reclamation project. Rather, we're articulating a particular way that personal responsibility has been deployed historically in policy, and trying to reckon with the tensions between its moves to responsibilize and the simultaneous importance of recognizing individual autonomy, which is, in effect, the ability of people to be responsible for themselves. This is why we think that a reproductive justice analytic is so important and also so useful. It's grounded in an affirmation of the importance of personal power and a belief in the capacity of people to act in their own best interests. But it is equally rooted in a recognition of the relationships between people making reproductive decisions and the social conditions that enable and constrain them. It is a profoundly non-individualistic framework that sees the necessity of things like paid leave and affordable healthcare as the conditions of possibility for reproductive freedom. So there are countless possible examples of personal responsibility in US policy. We've picked these ones because they're illustrative of its mechanics and because they bear on reproduction. And because while personal responsibility is a fundamentally conservative position, each of these historical examples was advanced by a democratic lawmaker. So we can't rely on simple political party binaries to understand the mechanisms of the harm incurred by policies that claim to center individual decision-making without providing mechanisms of support for it. So in 1965, the Moynihan Report took on the important task of acknowledging racial injustice. But it did so by articulating racism through what it deemed to be individual moral failings located at the level of Black families. It saw single motherhood, teen pregnancy, and women-headed households as failure of people to improve their own circumstances, in effect as the causes of the disparities that Black families experienced. Crucially, this translation of social phenomena into individual ideology enumerated individual level targets that could be built into policy to address the effects of structural racism. Then, in order to deliver on his promise to, quote, end welfare as we know it, Bill Clinton's administration passed the Personal Responsibility and Work Opportunity Reconciliation Act of 1996. This legislation aimed to reduce what it called welfare dependency by encouraging work through making aid conditional on the satisfaction of moralizing requirements for what a family ought to be. So it used welfare distribution to incentivize two-parent families and to promote abstinence-only education that was supposed to reduce teen pregnancy. It explicitly made personal responsibility a goal that promised to lift people out of welfare. And it succeeded in removing people from welfare, but particularly for people of color, these reforms did not lift people out of poverty. Then in 2008, in the wake of the financial crisis, Obama used his first inaugural to declare that what is required of us is a new era of responsibility, a recognition on the part of every American that we have duties to ourselves, our nation, and the world. Here again, the solutions to the complex institutional failings of financial systems and the unchecked workings of corporate greed are to be found in individual people working hard, making sacrifices, and picking themselves up by their bootstraps. Personal responsibility, then, is violently individualistic. It invents an independent person or family unit that ought not need things from the state and ought not be shaped by the social structures of their communities. So the mechanism of personal responsibility is responsibilization. It's a neoliberal shift in responsibility from governments to individuals. It moralizes, rendering conditional and personal behavior that which people are owed. So now let's turn to reproductive responsibility during the pandemic. The examples that will follow are of long requested policy changes that remove barriers to reproductive autonomy. And as our historical examples demonstrate, we've always held people responsible for their social conditions. But the pandemic allowed for the relationship between need and responsibility to be expressed differently by policymakers and the media. Think all the way back to spring 2020, when the media zeitgeist framed the pandemic as ubiquitous, as touching us all, as a great and terrible unifying experience for which we individuals were not at fault. I don't need to tell you the ways in which this was not in fact the case. We all know just how unequal the pandemic has been and that inequality is the product of the human decisions that made it. But the pandemic was made to do the work of removing the presumption that people are blameworthy for the social conditions that they find themselves in. People, so many more than before, need things because they are in a pandemic, not because they have failed in their personal responsibility. The immediate justification for each of the changes that I'm going to outline was health and the reduction of risk of COVID spread. But it's important to note that the need for each of these changes was known before the pandemic and that they would enhance autonomy after it. They are emergent and necessary, even if the necessity of the pandemic emergency no longer applies. The first of our examples is telemedicine supported abortion access, something that Professor Erdman will go into in much greater detail after me. At the start of the pandemic, abortion joined many other forms of healthcare as litigation made it accessible at home through telemedicine. The FDA's REM policy had long treated mifepristone, the first of two drugs required for a medication abortion, exceptionally on the pretextual basis of safety. It made the drug available only through clinics and hospitals and not by mail or at retail pharmacies. But when plaintiffs, including ACOG and the Sister Song Reproductive Justice Collective, got that policy enjoined in early 2020, it meant that people were able to remotely access abortion services. Access to abortion has been systematically decimated across the United States, particularly in rural areas. The right to abortion is constrained by financial barriers, by waiting periods, and by policies such as the FDA's that frame abortion as exceptionally risky in ways that are unsupported by scientific research. This policy change intervened in a small but meaningful way, relieving pregnant people of the burden of traveling, sometimes great distances, to see a provider, and of the risk of COVID exposure in doing so. In effect, It permitted pregnant people more latitude to make and be supported in their own reproductive decisions. In this case, barriers to access were removed, facilitating the exercise of responsibility rather than rendering access conditional on satisfying prescriptive and moralizing reproductive conditions. Under the status quo, some states require that young people seeking an abortion obtain parental consent in order to receive one. Without parental consent, they need a judicial bypass order. The pandemic moved these hearings online. The people that are made to seek judicial bypass for abortion access tend already to be economically vulnerable and racially marginalized. Such hearings demand painful intrusion into their private lives and the revelation of intimate details in order to justify their claims to abortion access. The requirement that they do so is couched in a logic of responsibility that presumes young people not yet responsible enough to make their own reproductive decisions, and it creates bureaucratic hurdles to make proof of their responsibility more difficult. We need only turn to the lack of corresponding concern over whether these young people are responsible enough to bear the children that would forcibly result in order to expose the hollowness of this supposed concern. Remote access to judicial bypass does not address the fundamental injustice of regarding young people as a priori undeserving of reproductive autonomy. But attending these hearings in person represents a significant and intrusive burden, and moving them online at least removes one barrier impeding access to reproductive autonomy. Finally, paid family leave is integral to reproductive justice, which emphasizes the need for systemic change even when no global health crisis exists. It is critical to financial independence and of life-saving importance for those many among us whose survival depends on giving or receiving care. It lets people care for themselves and for their families without risking losing their jobs, and it protects workplace communities from the dangers of workers who have no choice but to choose to come to the office while ill. This is obviously necessary outside of the pandemic, and indeed has been an advocacy target for generations. But the Families First Coronavirus Response Act is the first federal law of its kind. But its benefits are no longer mandatory and may soon disappear altogether, and it left far too many people out, many of whom are the minority workers deemed to be essential and whom we know to be most vulnerable to COVID. So these policies, meaningful as they are, don't solve the underlying injustices of the systems in which they reside. In early 2021, the Supreme Court returned telemedicine abortion to the status quo, removing the access gains that telemedicine had facilitated. Remote access to judicial bypass doesn't overcome the injustice of policies requiring it in the first place, and we need paid family leave well beyond the emergent conditions of the pandemic. Another key limitation of these policies, in particular telemed abortion and paid family leave, is that they are already primarily available to those with means, those with healthcare access or jobs from which leaves can be taken. So these were changes catalyzed by the pandemic, because millions of people are now experiencing new kinds of health vulnerability and caring responsibilities, and because public health requirements demand alternatives to in-person interaction. But the pandemic didn't invent these needs. These policy changes had already been the advocacy targets of people working towards health, disability, reproductive, and economic justice. These pandemic policy changes allow for an expression of individual responsibility that promotes personal power and makes it possible for people to take responsibility for their needs more effectively than without them. They are the sort of policy changes that we need, but they can't require something like the supposed blamelessness of a pandemic to bring them about. They are necessary, full stop, and just a start. A commitment to reproductive justice, which is a commitment to the attention to the conditions of possibility for reproductive flourishing, can help to identify needed policy changes, and it can help to establish frameworks for articulating them that do not re-entrench the responsibilizing, moralizing logic of personal responsibility as it has so long been enacted in US policy. Reproductive justice stands in ideological opposition to this regime of personal responsibility, where personal responsibility forecloses structural explanations for people's personal struggles while creating the conditions for many of them. The framework of reproductive justice is an explicit invitation to structural analysis and solutions that demand interdependence. When applied to contexts of reproduction and families, the ideology of personal responsibility generates policy that controls individuals' choices about reproduction, family structures, and their being in the world. Reproductive justice, instead, insists that people can and ought to be capable of acting in the best interests of themselves and their communities, and perhaps most importantly, of making their own calculations about what it means to be responsible. So responsibility is consistent with reproductive justice if it is not only available under the emergency conditions in which people are blameless for their need. The responsibility implicating policies that we have outlined are a good start, but progress is insufficient if it's available only to those already structurally empowered. Thank you, and this is my contact info.
All right. Hello, everyone. So it's great to be here, and thanks so much for the opportunity to share these projects with you. My project specifically asks what COVID-19 teaches us about the home as a site of healthcare, and more specifically as a site of abortion care. In the article, I track COVID-19 reforms in Europe and the US, which allowed for the remote or telemedical provision and local delivery of abortion pills, such that people could have abortions at home during the pandemic. Before COVID-19, in all 5 countries, Ireland, England, Wales, Scotland, France, and the US, an in-person clinic visit was required to access abortion pills. These home reforms have been rightly celebrated as a significant measure to ensure equality of access to abortion as essential health care, while protecting people from unnecessary exposure to the virus. But as a scholar of abortion law, I'm also interested in these reforms as spatial regulation. Abortion has long functioned as a kind of zoning law, moving people from spaces of commercial markets and back alleys into hospitals and clinics. Indeed, if you take a long view, early 20th century criminal abortion reforms in Britain and the US targeted a growing commercial market in home use abortifacients, patent medicines, and ladies' remedies, often useless pills and tonics, but threatening nonetheless, particularly threatening in making public and profitable the commonplace of abortion in middle-class homes. With these reforms, abortion was taken from the home and sequestered in the clinic. Indeed, this is the logic of abortion law, even today, and even of liberal variants. It's a logic of controlled access through enclosed space, both figuratively and literally. Abortion is lawful only within the provisions of the law. These include provisions that authorize places of care where an abortion may take place. Now, most scholars study such regulation as barriers to access, restricting supply. But I've also always been interested in how such regulation shapes care within these spaces, how it shapes practice and subjectivity, what people do, and how they feel about it. Think about the abortion clinic, which especially in the US context began as a feminist or outlaw space, but with legalization became, often by necessity, a place of medical treatment under professional supervision, a means to ensure safe services for patients, but also to ensure controlled access for an ambivalent public. And so imagine the radical idea of the post-clinic abortion, which the advent of abortion with pills made possible. An abortion not just outside the physical structure of a clinic, but also outside the control logic of abortion laws. Abortion at home, in the market, online. When the abortion pill was first introduced into the US more than 20 years ago, the cover of Time magazine heralded the pill that changes everything. But it didn't. Abortion pills were folded into existing abortion law and made subject to its norms and conceits. National regulatory agencies adopted strict prescription and dispensing controls. Indeed, even in liberal legal context, home abortion remained but an idea. It was advocated for years, even decades, but without success. That is, until COVID-19, when clinics shuttered and hospitals overfilled, and the radical idea of abortion at home found its revolutionary context. Or did it? Rooted in the spatiality of abortion law, in this article, I explore contrasting visions of the COVID-19 abortion reforms, and I'll just sketch those today. In the first vision, I study the home abortion as a pragmatic and conservative reform. As constructed by law, the COVID-19 reforms are all time-limited measures. They are born and bound to a historic state of emergency. They are backed by public health need and authority, and they are rooted in a crisis management discourse to ensure essential services, to minimize exposure, and to conserve healthcare resources. And it's this last feature, this crisis management discourse, that I find most interesting in these reforms. Most interesting because it taps into that popular idea that crises create the opportunity for radical reform. But historical experience suggests otherwise. In the thick of crisis, reform is often not a priority, at least not for political and legal authorities, for whom the imperative is to bring things back to normal. Core values, existing structures become anchors in an uncertain world, and reform comes only in the desire to change something so that the rest can stay the same. And this proves so true of the COVID-19 home abortion reforms. Let me share a few examples as to why. Well, first, rare is the acknowledgement of any reform at all in these policy changes. Rather, there is simple practice innovation. Irish authorities insisted on a simple alternative model of care, doing the same thing a different way. Telemedicine is still medicine, and examinations are still examinations, even if they happen by phone or video. The home is really no different than, and most importantly, it is not inferior to the clinic. This is a convention of public health research in the field, the non-inferiority study, whereby home abortion is not unacceptably less safe, or it does not come with substantially worse outcomes than the status quo, the clinic abortion, which in all of these studies and all of these policy reforms still remains the standard of care. Indeed, the routine citation of this research in support of these reforms softens any radical edge to them. This is a pragmatic intervention, and more so because research evidence is always itself revisable. So too is any regulation based upon it. This was the second feature of all of these reforms. They are temporary, time-bound to the pandemic, or in the US context, shorter-lived when the reform was reversed. And all of these reforms are temporary in a spatial sense too. They sit adjacent to the permanent structure of the abortion law, which in all cases was left standing. In each country, the existing abortion law and its logics anchored the reforms, whether that law be a criminal law with health exemptions, regulatory laws of drug safety, or even constitutional laws of fundamental rights and undue burdens. There was in every case this continued legality of abortion. It was assured in every reform, and it was assured especially as against a second feared pandemic, a fear of unsafe abortion in the unregulated markets of people buying and selling abortion pills online. But this conserving of the status quo was most evident, I think, in a third feature of these reforms. And this was the promise that medical practitioners would remain in charge. And indeed, medical organizations led the charge for reform in every country. No-touch protocols promised that clinics could and would do everything they ever did to supervise patients and to administer abortions safely, now within the home. When the UK reforms were challenged as ultra-virus of the criminal abortion law, which required that all abortions be carried out by a registered medical practitioner, the courts here defended the reforms on this idea. Doctors would remain in charge throughout, even in a public health emergency. And so the COVID-19 reforms, on this account at least, are indeed pragmatic and conservative in nature. And yet, I think these reforms may yet prove radical in legacy. Because while the law may anticipate the home as a site of abortion care, and it might even set a vision for the home as a site of abortion care, the fact remains that the home is a real space. It's a space made meaningful by those who live there and who will make abortion within it their own. And so in the second half of the article, I want to focus on this vision of what I call homemade abortion. The ways in which people will transform their homes into places of abortion care, unbounded by the regulatory structures of the clinical care, and ways in which it intersects with the everyday tasks, products, and people of home life, and how abortion as a consequence will be opened up to this radical diversity of practices and norms. I think especially during the pandemic, when people are forming new relationships to their home and investing new meaning in it. And so with the remainder of my time, I'd like to share just a few features of this vision of abortion at home, the home as an inhabited space of abortion care and abortion law. So first, I think the reforms may indeed break their promise, and they may break the medical model of abortion. And this is not least through the fact of having practice innovations and protocols that simply give people greater control. Think about pregnancy dating by last menstrual period, or abortion follow-up by home pregnancy tests. And most importantly, step-by-step instructions on how to do abortions, how many pills to take, how to take them, how to care for the patient yourself throughout. There's just a know-how quality to this information, an active sense of people using their cheeks and their tongues to do it, relying on their hands and their eyes to feel and see what's happening. This is the blood and guts of abortion. At home, patients do things, they experience things, they know things that an authorized medical practitioner simply cannot. This is not abortion managed, it is abortion experienced. And this is different than informed consent. It's a transfer of knowledge and power and an acceptance of non-standardized practice. Because in their homes, people will take creative license, they'll improvise, they'll improve on practice, they may even create new practices. The idea here is that there are other ways of knowing and doing abortion. And this is a second feature then, that against the pragmatism of the COVID-19 reforms, there is just this practicalism of the do-it-yourself abortion. Its practices are shaped by the material and the social relations of the home, the vernacular. You might think here of YouTube videos, Reddit threads, abortion apps. Indeed, one is affectionately named the Abortion Siri. There are any number of popular magazines, all of which now promise everything you ever wanted to know about abortion at home, where people speak in their own voices, they narrate their own experiences, and where information is judged here by its usefulness, not its origins. People use these platforms not only to share knowledge, but to produce it. And I think it's a knowledge that others will extract and embed in new services and products. Indeed, the at-home use and consumption of abortion pills invites a whole new way of thinking about and relating to abortion. And this is not least because abortion pills are commodities. And under the COVID-19 reforms, they are acquired in ways common to other household products of need and leisure. Think about it. Abortion kits are mail-ordered, home-delivered, picked up in local retail pharmacies. Other home abortion paraphernalia like pregnancy tests, ibuprofen, soothing teas, they can just be added onto your Amazon shopping cart. In the US, immediately after the reform, online clinic startups, advertised services, and online pharmacies began shipping mifepristone directly to patients. You know, abortion services have always functioned as a market. But in Europe and the US, abortion was rarely seen or talked about as such. And this was especially true in law. But with home abortion, the market has become more diverse, extending beyond these large service provider household brands. And though the COVID-19 reforms were expressly designed to extinguish this alternative market, I think that as people become more familiar and more comfortable with abortion at home, a more mundane affair, the protocols of regulated access may also become more burden than protection. And this will generate a new consumer class, less patient. Indeed, there are other ways in which the COVID-19 reforms may wrongly assume a continuity rather than a transformation of abortion care when it returns to the home. And this is in the norms of abortion care, a third and final feature. You know, different visions of privacy, for example, they just may attach to abortion in the home, where it's less about a right to a space from which others are excluded and more perhaps about a space of intimacy in which others can join in, a collective and shared experience of abortion. Abortion as a less solitary act, and an abortion instead as an intimate act among friends, partners, and with families. It becomes a meaningful part of home life, opening up the experience to new emotions and associations, new ideas about what makes an abortion safe or good. And so with nothing presumed or naturalized about the home, in fact, here you might have quite the opposite, where we come to know more intimately the deep structures of inequality that shape home life, the care burdens of young children, the scrutiny of abusive partners, the loss of household incomes, the loss of housing itself. All of this might come to inform abortion decisions of people, and it will make abortion at home not a self-evident good any more than staying at home is during a pandemic. And so let me conclude here that in the end, the fact of the matter is the home is a space of intimacy and isolation, protection and risk, freedom and constraint, care and consumption. But I think that it is within these complexities, these contradictions of home life, that the radical legacy of these COVID-19 reforms reside. Abortion at home just puts people in touch with values and practices of another space, and they will act and experience abortion in ways authentic and responsive to that space. There's this idea in law that if you occupy a space openly and notoriously, no one can force you out. You can claim legal title to it. And so like space itself, I think these abortion reforms will come to bear the imprint and the lives of their inhabitants. This is an abortion law that may have been born of public health need, but it will be habituated in the home. Thanks so much for listening.
Hey, everybody. Thank you so much for to our hosts, and it's such an honor to be up here with my co-panelists. I'm going to take a step back and talk and think more broadly about our social safety net. So obviously, our social safety net supports people with food and cash and health insurance, and these are vital inputs to people's health, and it gets to the structural and intermediary determinants of health that Seema talked about a little bit before. So that's what I'll be thinking about for the next 15 minutes. So I am co-authoring this work with Andrew Hammond at University of Florida and Gabe Scheffler at University of Miami. And our chapter examines the federal government's response to the COVID-19 pandemic, and we look specifically at changes to safety net programs. We ask what went wrong, what lessons can we learn, and how can we improve crisis response going forward? So just to give a quick roadmap of what we're going to do today, we are going to give a brief overview of what the federal government did in response to the COVID-19 pandemic, talking about what went wrong. We note problems of delay, problems of politicization of the crisis, and inadequate support to many groups. And this leads us to conclude that the response should be depoliticized and perhaps made more automatic. So we talk about several reforms, and we specifically survey the literature on what's called automatic stabilizers. And then we spend some time defending automatic stabilizers from critiques based on accountability or democratic legitimacy. So I'll spend the last few minutes of the presentation talking about our thoughts on that. I specifically focus on the tax system and on unemployment insurance in this piece. So I'll probably spend a little bit more time on those. So maybe a little bit of a much deeper determinant of health. Okay, so starting with what's been done so far. So how did Congress use the safety net to respond to the COVID-19 pandemic? So 4 major ways that we look at, and the 4 big ones were cash payments through the IRS, unemployment insurance expansions, and expansions and changes to food assistance through the SNAP program and medical assistance through Medicaid and other regulations surrounding health insurance. So starting with the IRS and unemployment, as we probably all know, the federal government sent out rebate checks to people, a first round of $1,200 per person and then a second round of $600 per person. The first round excluded families where one member lacked a social security number. The second round included those families, which brought support to 16.7 million additional people who were previously excluded. The latest round of stimulus reforms also changed the earned income tax credit and the child tax credit. So taxpayers can now use their 2019 or 2020 income to calculate the amount of the credit. So because the credit phases in as income increases, this will prevent them from losing benefits or getting a smaller credit because they lost work or because they're getting unemployment insurance. So this is an important change. And then Congress also deferred the payment of payroll taxes for a year. So anyone that didn't pay payroll taxes under a change in 2020 won't have to pay back those taxes for a full year. For unemployment insurance, the federal government provided a weekly supplement, first of $600 per week, which ended in July, then of $300 per week. This latest one lasts for 11 weeks. Congress also provided federal support for lost hours. So that means that if somebody didn't lose their job completely, but has now works fewer hours, they get additional federal support, although that provision wasn't extended in the most recent bill. They also provided extended unemployment insurance coverage for anybody whose state benefits have run out. So you run out of state benefits, you get more weeks of federally funded unemployment. And the latest round of this lasts until March 14th. And then finally, they provided federally funded coverage for self-employed workers or gig workers. This is a change people have been asking for a long time. The latest bill extends that coverage for another 13 weeks, but hopefully they'll extend it longer. For food assistance and medical assistance, so Congress authorized the pandemic EBT program, so states can send food support to families who would have been enrolled in free school lunch for their children through school. So now states can send cards with food support for those families. The CARES Act also increased SNAP funding and blocked a proposed regulation that would have denied SNAP to 750,000 Americans. These are mostly childless adult workers. And this was a regulation that the Trump administration had been trying to promulgate for a while. And then the latest Appropriations Act also increased SNAP benefits by 15% for all beneficiaries. And then on medical assistance, in the Families First Act, Congress increased the federal match percentage, FMAP, for Medicaid, conditional on certain things, not excluding certain populations and meeting other conditions. They also mandated that insurance cover testing costs and other things associated with those testing costs, and they gave some extra support to states and healthcare providers to cover COVID-related expenses. Both food assistance and medical assistance started providing online access. So people with SNAP benefits can order delivery groceries through a purchasing pilot, and Medicaid covers telehealth. So both of those were important changes. So that was just a very brief flyover. There are a lot of details that I skipped over. But from looking at all of those changes, we noticed, and a lot of people have noticed, that the federal response had quite a few problems. So first of all, the response left behind the same people that are very often excluded from safety net programs. First of all, immigrant families received smaller benefits or were excluded, so undocumented workers are simply not in the system. They aren't eligible for most benefits. Mixed status families didn't get, as I said, they didn't get the first round of stimulus checks, so they're getting fewer benefits. Childless adults are historically excluded and deemed undeserving in our safety net programs. They are mostly left out of the earned income tax credit. It's very difficult for them to get benefits through other programs like food stamps. And then the already unemployed. So unemployed individuals, again, are historically excluded from most safety net programs. And in the case of COVID changes, they didn't benefit. So in order to receive unemployment insurance expansions, your unemployment had to be caused by the pandemic. So if you lost your job before, you didn't fall into that category. And that's true even if their continued joblessness was pandemic related. So just a continuation of this pattern of exclusion. A few other problems. So delay has plagued all of these expansions from the beginning. Congress did not increase SNAP benefits for everybody until the very last round of stimulus in December and January. The Trump administration failed to reopen the ACA enrollment in the federal exchange, which affected 38 states. So people in 38 states couldn't enroll in medical insurance, which the Biden administration, it took until the Biden administration to rectify this problem. There have also been massive implementation issues related to technology and administrative processes. So Florida's unemployment insurance system has been plagued by technological problems from the beginning. The system crashed. Most of the benefits that were distributed in Florida were federal benefits because of these problems. Tennessee implemented an unnecessarily complicated enrollment process for pandemic EBT. So a lot of families were excluded or didn't get benefits when it should have just been an automatic process of sending pandemic EBT cards to families whose kids had been receiving free school lunch. And then we also note that the politicized and the decentralized nature of the response emboldened governors to refuse aid for political reasons. So just a couple of examples. In South Dakota, Governor Noem refused a weekly unemployment insurance boost of $300 that the Trump administration offered in August. In Nebraska, Governor Ricketts refused extended SNAP benefits in the fall, despite the fact that there were many families going hungry in that state. So the response was delayed. In some places, it was very badly managed. It was exclusionary, and it was politicized. And these problems are not going away. They're continuing. Congress has been unconscionably tardy, and it has been dragging its feet. There was presidential inaction for quite a long time. Families were left with far less support and insufficient support between August and January, when Congress was unable to pass additional stimulus. Throughout the response, there has been very little support for states, and especially for local governments, despite the fact that local governments are providing a lot of the frontline services that people are relying on, including county hospitals, healthcare, and mental health facilities, nursing homes, things that are at the front line of the pandemic. And also, some places are continuing to suffer disproportionately. So the whole nation is affected, but a lot of places are suffering more than other places. And the locus shifts around. So at first, New York was suffering, perhaps more than other places, Los Angeles more recently. So the reach of the crisis is wide, but the depth is uneven. And none of these problems is going away anytime soon. We are seeing the possibility of additional stimulus. We're seeing signs of an improved response going forward, but it's really too early to tell. We might see more stimulus checks. We might see a child benefit, but we just don't know yet. So we think we can learn from these mistakes. We think we can draw out several principles to dramatically improve crisis response for emergencies in the future. And specifically, we think that crisis response in the future should be immediate. We should respond quickly without waiting for congressional action. We think it should be inclusive. We should not be excluding people who have been historically excluded from safety net programs. We think it should be targeted. So target the people and the places that need it most, rather than distributing equal benefits to everybody, even people who aren't as affected. And it should be sustained. So any expansion needs to last the duration of the crisis, not merely for a couple of months when Congress at the beginning is able to get its act together. We specifically think that there's a possibility of using or strengthening automatic stabilizers to achieve some of these goals. An automatic stabilizer is a mechanism that is built into government budgets that doesn't need congressional approval, that increases spending or decreases taxes when the economy slows. So it injects more money into the economy. Now, of course, safety net programs already are automatic stabilizers. The SNAP program and unemployment insurance and these various programs give more money to people when the economy slows because more people claim these benefits. But we think they could work better. So I'll just, in the last couple of minutes, talk about make two different points. So one, we surveyed different proposals to strengthen the automatic stabilizer effect of safety net programs. So we just, looking at different ways that other people have proposed that we could enhance the automatic stabilizer effect of our tax system, unemployment insurance, the Medicaid program, and SNAP benefits. So for example, for tax benefits, basically increase how quickly we're getting money to people and how much money we're getting to people. So increase how quickly these credits phase in at low income levels, expand eligibility to cover as many people as possible, and this means covering childless workers, perhaps mixed status families, and allow people to get the credit during the year when they are suffering. For unemployment insurance, similar reform proposals. So expand eligibility so that gig workers are included permanently, expand eligibility for people who have lost hours, make that permanent. And then for all of them, make all of these expansions automatically triggered by economic indicators, not reliant on congressional action. So make these expansions triggered by unemployment rates, the speed of increases in unemployment, the SAMHSA recession indicator, things that are outside of congressional control. So all of these things would automatically increase benefits during a time of crisis and would essentially cut out the congressional middleman. Now, in my last 2 minutes, we think that automatic stabilizers deserve some defense. So there hasn't been a sustained pushback against automatic stabilizers, but we could anticipate, and I have heard people make some critiques of automatic stabilizers based on accountability or government legitimacy. Basically, the argument is stabilizers take control out of Congress's hands, and really we should be letting lawmakers decide at the time of the crisis how to respond. So we plan to anticipate and respond to these critiques. And our general argument is just that automatic stabilizers do not undermine government legitimacy and actually may improve governmental accountability and legitimacy for a couple of reasons. So first, deliberation. We think that legislating outside of a crisis in a non-emergency context gives more space and more opportunity to deliberate. We think it gives especially more space for a richer democratic process. Okay, I'm running out of time. So I'll just quickly mention delegation and federalism. So we also think that giving more specific rules to agencies would improve delegation. And we believe that on the federalism point, that lawmaking outside of a crisis would depoliticize the process and allow states to receive depoliticized, more equal support when a crisis hits. So thank you so much for listening, and I will end it there.
Great, thank you so much to all of our panelists. I am aware that we are basically at time, but as long as you guys are willing to stick around for just a few minutes, we'll just do one quick lightning round. I see that there are a few questions in the Q&A, and thankfully most of them are directed to one of you specifically. So I will leave it at your discretion to take those in, and if you want to type an answer out to respond, I encourage you to do that. The one lightning round question that I would like to pose to all of our panelists before we wrap up, and it is if you could tweet out just one take-home message from your talk today that you would want the audience to take away from listening to your talk, what would it be? And why don't we start sort of in the middle of our list? Liz, do you want to go first?
Sure. Thank you guys so much. These talks were just wonderful to listen to. Okay, so I think my tweet length takeaway might be that personal responsibility is everywhere in US policy. And COVID-19 shows us how reproductive justice can help reckon with the need to respect reproductive autonomy while not conditioning access on blamelessness.
Great. Joanna?
Thank you. I would just say, the last line of my presentation, I think though born of public health need, like so many of the reforms, I think we're really hoping that they will be habituated in the lives of people to make them real and meaningful. Thanks.
Ariel?
I would say that the safety net has been broken for some time, but that we can learn from our mistakes to build a system that better supports all US residents.
Seema.
I would say children need attention and resources.
And last but not least, Zoe.
Thanks again, everyone, for the opportunity to speak. So my tweet would be, it took a pandemic for regulatory agencies to change methadone regulations. Freeing methadone saves lives, decreases overdoses and infectious diseases, and we need permanent changes to regulations now.
Excellent. We are so thankful to have had such a wonderful panel. My apologies that since we did have such a super stacked panel that we didn't have a lot of time for Q&A. I will also mention just one quick thing. We will have the video of today's panel posted to our websites after in a week or two after it's been sent out for closed captioning. And I would encourage you all to go to our websites and register for the next panel in our series, which will be next week on Tuesday, February 23rd at noon, focused on the use of biotech in the COVID-19 pandemic. Thank you again to all of our speakers, and we will see you all again soon. Thank you.